طيب, Assalamu alaikum. Good afternoon, everybody, and welcome back from Eid holiday. I'd like to welcome you today to our grand round, and it is my pleasure to introduce our speaker, Dr. Hussam Razqan. Dr. Razqan is a young consultant in the cornea and anterior segment division at King Khalid Eye Specialist Hospital. But despite being early in his career, he has shown great dedication and promise in this field, with growing interest in managing complex cases and exploring innovative surgical techniques. Today, he will be sharing his experience and insights on the clinical profile and outcomes of combined pars plana vitrectomy and keratoplasty using temporary keratoprosthesis, a challenging approach and often reserved for eyes with severe anterior segment and posterior segment pathology. So please join me in welcoming Dr. Razqan.
Thanks, Dr. Rafa, for the kind words. Assalamu alaikum, kull aam wa antum bkhair. Good afternoon, everyone. Hope the break was sweet because now we'll shift from dessert to detached retina, diving into the fascinating world of temporary keratoprosthesis. So the temporary keratoprosthesis was first described in 1981 by Morris Lander. He introduced this device to be used in combined cornea and vitreoretinal surgery in the presence of posterior segment disease and concurrent corneal opacification. It was designed to enable retina surgeon viewing the posterior segment with less chance of complication in a closed system vitrectomy. And Morris Lander, by the way, he is a vitreoretinal surgeon. The first TKB was biconcave in shape, the picture on the left side of the picture, with optical cylinder of 5 millimeter in length and BMA material, and had 7.2 millimeter in diameter. This device continued to evolve till we reached the third generation of wide-field TKP in 1993, which has the feature of less cylinder protrusion to 1 millimeter and expand the corneal surface diameter to 15.5 millimeter, which improve peripheral retina visualization. It is also reusable and enhance the durability of surgery by maintaining intraocular pressure. It comes in three sizes, which are 6.2, 7.2, and 8.2. So, given it is reusable, it also the disadvantage of it is being vulnerable to scratches, which compromise the view over time. And when we refine it, for example, the 6.2 size, we choose the trephination to be 0.2 smaller than the elected or chosen device size. The other type of clinical use of TKP is Eckert, that developed by Klaus Eckert in 1987. It is silicon-made material with a hydrophilic surface. It is flexible and it adapts variable corneal size. The limitation of this device, it has less durability than the BMA counterpart, as there were no holes for suture, and the silicon became damaged after multiple suture track. The view into peripheral retina was limited as well with the silicon one. Our aim of this study to evaluate the clinical profile, complication, anatomic and functional outcome of eyes that underwent combined pars plana vitrectomy and penetrating keratoplasty using Lander third generation of wide-field temporary keratoprosthesis, in addition to identify pre-operative ocular diagnosis and indication of combined BVV and BK. Our study design is a retrospective chart review of the medical record. We include all patients who had BVV, BKB procedure using the TKB in the period of June 2014 till December 2022. Our demographic data show a total of 46 eye enrolled in this study with a mean age of 36, 30 of them being male while 16 being female. In the ocular comorbidity, we notice half of our data had trauma history, around 23 cases. 18 eyes had glaucoma, and around 27% had corneal issue, whether congenital corneal disease like anterior segment dysgenesis or keratoglobus, or secondary corneal issue like in microbial keratitis, corneal edema, and neovascularization. History of complicated cataract surgery was present in 7 cases. History of infectious endophthalmitis present in 1 case. Recurrent retinal detachment, 10 cases. ROB, 1 case. Hemangioblastoma and von Hippel-Lindau disease in 1 case. And hemorrhagic choroidal detachment in 1 case. The preoperative lens status were ephikic in 26 eye, phakic in 14 eyes, and pseudophakic in 6 eyes. This graph presentation, this graph presents the distribution of surgery performed over the study period. Interestingly, most of our cases were performed, were operated in 2020. We attribute this to the decreased number of elective surgical cases at that time as a result of COVID-19 lockdown. So surgeon was more willing to operate in low potential cases, even with long operation time, in addition to be an eye center open at that time for emergency referral cases. The primary surgical indication for BK was traumatic corneal scar by 32%, followed by corneal edema, or failed graft in 25%, then corneal edema in 18%, followed by MK, corneal scar, and corneal blood stain. Other indications that include anterior segment dysgenesis and corneal melt with keratoprosthesis exposure. The highest number indication for Plana Vitrectomy was RD, representing almost 70%, followed by endophthalmitis, vitreous hemorrhage, silicone oil removal and re-injection, management of drop nucleus, and so on. The anatomical and functional outcome, the corneal graft failure occurred in 25 transplants, representing 54% during the follow-up period, while the retina remained attached until the last follow-up in 37 eye. We observed a trend that from 2015 to 2017, the proportion of failed graft were higher compared to the graft remained clear during the same period each year. We attribute it to the less follow-up period of the later group. In 2018 and forward, the proportion of both failed and clear graft were comparable for each year. Despite the minimum visual improvement that was noticed in 3 months post-operatively, it did not last long on the last visit, with a mean follow-up period around 2 years. This table summarizes the variable we analyzed in relation to a graft status. As you can see, a history of ocular trauma was quite common and showed a nearly 50% rate graft failure, which aligned with our expectation. Variables like active microbial keratitis, aphakia, and the need of subsequent surgical intervention were all associated with high rate of graft failure, over the 60% in each group. However, these findings did not reach statistical significance, mostly due to the relatively small sample size. Intraoperative complication, we noticed 8 cases had Plana Vitrectomy related complication, and these are heterogenic break, choroidal detachment by the trocar insertion, leaking sclerotomy, and all complications were managed at the same time during the surgery. The highest post-operative complication in anterior segment part were corneal graft failure, followed by glaucoma development, followed by microbial keratitis and rejection. While in the posterior segment part were RD, recurrent retinal detachment with and without BVR, then hypertony in 11 cases, phthisis bulbi 4 cases, endophthalmitis, suprachoroidal hemorrhage, and other complications like sterile vitritis, epiretinal membrane, cystoid macular edema, rebound fibrinous inflammation, emulsified silicone oil, and migration to anterior chamber, and choroidal detachment. Subsequent procedure, 11 cases had additional vitrectomy, 4 had a second combined procedure. BBV and PK. One case had additional penetrating keratoplasty. One case had scleral buccal surgery. One case underwent evacuation due to panophthalmitis, and the organism couldn't be identified. Clinical outcome of combined procedure using TKB have been looked in literature with variable outcome that is mainly due to the small sample size in this kind of surgery, variable follow-up period, and underlying ocular comorbidity. The rate of graft failure in literature was ranging from 20 to 85% in different studies. In our study, we attribute the relative high rate of graft failure, around 54%, to the nature of our tertiary care institute, which is a referral center for complex cases in the region. Therefore, our cohort have a high incidence of ocular comorbidity that include glaucoma, anterior segment dysgenesis, microbial keratitis, corneal neovascularization, aphakia, and the need of concurrent procedure or subsequent surgery. These factors have been found in literature to greatly compound the risk of graft failure. In keeping with literature, we have noticed that all patients who had microbial keratitis, episode of graft rejection, required second combined BBV-PK procedure and up with graft failure. Two-thirds, around 65% cases who had additional procedure ended up with graft failure as well. However, those were not statistically significant. In a recent paper by Julia Yu in 2023, she reported a graft failure rate of 61 with a retinal reattachment rate of 91%. Attributed the graft failure rate to the high incidence of underlying ocular comorbidity, open globe injury, and prolonged silicone oil tamponade. She also demonstrated a significant association between these factors and the increased risk of graft failure. Silicone oil is often preferred by retina surgeons in complex retina detachment due to its effectiveness in maintaining the retina attached. However, several studies have associated prolonged silicone oil use with corneal endothelial dysfunction potential leading to a graft failure. The risk is heightened in aphakic eye, where the absence of lens permits direct contact between the silicone oil and the corneal endothelium. The situation is further compounded by underlying inflammation and the ocular comorbidity, which often preclude lens implantation and contribute to a graft compromise. In our study, out of all graft failure cases, 80% had permanent silicone oil tamponade and 64% were aphakic. Regarding recipient age and graft survival, there were no consensus on the impact of recipient age on graft survival, as Louis et al. Reported poor graft survival in pediatric patients compared to adult. He attributed to a more robust immune response and increased risk of graft rejection, also linked to high rate of associated cataract and glaucoma at this age group. Other studies have shown the opposite, which is increased donor and recipient age may be associated with a higher risk of graft failure. At the final follow-up, 37I had sustained retinal attachment, which represent about 80%, and silicone oil was retained in 81% of those eyes. These findings are consistent with previous reports which have shown favorable anatomical outcome with silicone oil use in combined BBV-PK procedure. However, it's important to note a key limitation due to the high rate of graft failure in our series. Many of the retina attachment assessment were using B-scan ultrasonography. This presents a challenge as the reliability of and the accuracy of ultrasound is significantly reduced in silicone oil filled eye due to the attenuation and the reflectivity of the sound wave. Visual outcome are often limited in combined procedure due to the high rate of graft failure, trauma-related damage, and underlying ocular comorbidity. In our study, no significant visual improvement was observed even in eye with a clear graft. Despite this, globe preservation remained a high-value outcome in many cases. The limitation of this study being a retrospective in nature introduce a potential selection bias. Surgery were conducted at a single tertiary referral center with multiple surgeons. Relatively small sample size that reduced the statistical power and variation in follow-up duration. In summary, the use of TKB in combined BBV PK surgery is a valuable tool in the management of complication ocular cases, without which many eye might not be possibly saved. High rate of graft failure was not in this type of surgery. Was noted in this type of surgery. Poor visual prognosis despite high rate of reattached retina credited to the poor tissue damage or underlying ocular comorbidity. A careful patient selection and enhanced patient counseling about the long-term potential for this type of surgery is important to avoid unwanted complication. And I would like to extend my thanks to all members of research team for their invaluable contribution. Thank you. Yes, please go ahead.
3 comments. The first is you talked about microbial keratitis, right? So I'm just curious, is there a specific set of organisms that infects the corneas under this situation where you have PPV with corneal grafts?
Yeah.
Or is it just a broad range and nothing specific?
We did not look into that, actually. Yeah, we did not look into that.
Just out of curiosity.
Mm-hmm.
The second is related to, what was the second one? The graft failure in people with silicone-filled eyes. And most of your references are fairly old, and I'm not an expert in this.
Yes.
But, the oils have changed, the purity has changed, and this is, again, a biased personal observation on the glaucoma service. It's not that high, the graft failure rate with silicone in the eye. You don't see that many decompensated corneas. Now, I don't know, do we have a large cohort where you could look at this? I mean, of course, there are various variables, but what's the current rate? I mean, what do I tell a patient that who has silicone oil? What's the likelihood of your graft failing? Of course, there's glaucoma also there, but it doesn't seem to be that frequent, and I might be wrong.
Mm-hmm.
You probably see more of that than I do.
Mm-hmm. Well, we have noticed an association actually with the silicone oil and the graft failure. It was not significant in our cohort, and most of the study are retrospective, which is a potential for selection bias. But they have noticed also in recent study, the one I showed in 2023, there was association between a prolonged silicone oil and graft failure with clinical significant p-value.
And does it make a difference what kind of oil you use, or
usually in those kind, maybe the retina team can answer better, but when we were reviewing the data, they used the heavy silicone oil.
Silicone.
Yeah.
And the last comment is the analysis of the small data set. I'm wondering if the differences are fairly large in some of whether using an odds risk ratio may be something differently to look at, maybe talk to the statistical team rather than I think they probably use some other non-parametric test, right?
Okay.
Rather using a risk ratio. It may be something to consider. So.
Sure. Thank you.
Yeah, thank you for this actually to present your study, which is give us more ideas. Looking for the alternative for silicone oil, actually the gas, and the gas actually in this case is not the good tamponade, as it is already there is BKB and there is a lot and could be lost and so. So the silicone oil and density of the silicone oil is important in these cases. It's preferred to go with 5,000 type of silicone oils. Silicone oil in contact with the endothelium for short period is not that really having the bad effect as that you consider. And it might be drying, the graft. But leaving that for a long time, it's starting to have the issues. Having a lot of multiple factors in these cases, like as you said, microbial keratitis. There is the ciliary body is not functioning well. In addition to silicone oil, all these factors might lead to. So we need to have the studies that to dissect all this together, and then we can say 100% the silicone oil is the cause. Temporary keratoplasty is a great one. We have used it, having good view mostly to the retina. You have to have certain techniques when you do it, not just only as the conventional vitrectomy, so that you are putting, perfluorocarbon, leaving that, getting back, and doing air fluid exchange with the difficulties after you removing the temporary and putting the graft, the few. So all this is, together, usually it's not that pleasant, and the long, procedure itself with BFR in these cases, because most of these cases not an acute, usually presented either after trauma or even though for long standing RDs. Glaucoma is one of the things that we have to think about it, especially that might increasing the risk of graft failure, especially in these cases. It's difficult to be controlled.
Yes. Thank you, Doctor.
Dr. Hussam. Thank you. Excellent talk. I've got one question. I'm a bit confused. When you say microbial keratitis, these are patients with active microbial keratitis,
Yes.
or they had a history of microbial keratitis?
No, active microbial
Because that
keratitis.
seems to be quite high.
Yes.
And what was the reason of doing a PPV in these cases? Like, was it because most of your cases were detachment.
Exactly. It will be
But most of the corneal cases were microbial keratitis.
So,
that combination is not making sense. But
the indication usually is either endophthalmitis or choroidal detachment when it's combined with microbial keratitis.
If you go back to your slide where you said the indication for, there were two sort of a pie charts.
This is it.
So RD without PP or RD with PS. So the huge number is?
So the MK is around 9% of indication. The highest indication of BK was the traumatic corneal scar. Followed by BK. Then
okay, I thought
edema,
microbial keratitis was high. Okay, so
it's only 9%.
Okay, that's excellent. Coming back to Dr. Edward's point is that if silicone oil is there and if the patient is aphakic, then for sure the endothelium will be compromised in a while. If patient is pseudophakic, it will take some time. In phakic patients, obviously because there's a good barrier there. But if you leave the oil long, and these are the cases where the oil has been left for long term because of the chronic RD or PVR.
80% of the failed graft we have very prolonged silicone oil.
Yeah, so once silicone oil is emulsified, then obviously it comes through the zonules, whether the patient is pseudophakic or phakic, and then it will certainly do its damage to the endothelium. Yes. The third thing is basically, and this is the problem with a rift basically between our retina colleagues. They always term us lazy guys. We don't want to do corneal transplant in these cases. Because we think that these grafts will fail. But the very important thing, if you can tell how many of the patients retained their visual acuity, how many improved, and in how many cases it sort of declined.
So this table shows...
Yeah, so this is slightly, if you can...
So we have noticed at 3 months where the cornea is supposed to be clear.
So what is 38% means, or 82?
No, we were able to take the VA at 3 months for 38 patients out of 46.
What do you mean you were able to?
Yeah, we couldn't take the VA for all 46 cases at 3 months. Only 38 of them. That's what this means.
Okay. So for your future publication, it's very important if you can stratify your cases, or we can put an argument in how many cases it improved, in how many cases you were able to stabilize it and preserve the globe, and how many cases this visual acuity got worse or the eye was lost. Sure. That'll be good. Thank you. That is one of the most important factors, and for us to decide whether we should do these sort of complex cases or we should be more careful for these cases.
And the visual acuity is not recorded. That means we have an issue. To be honest with you, I will not having this patient, might be I will see him today and after 3 days it's okay. but at least, you know, I don't know what's that, يعني. Or this has been done for a long time during, you know.
No, it was all collected from the medical record, but the issue with those type of patient, they already have or present with poor vision. And the early post-op, there is corneal edema and silicone oil, which is make it difficult to take the VA. Sometimes we have missing patient does not come. They have only 2-month follow-up. So all of those factors compromise the ability of standardize the visual acuity for all cases in such procedure.
Even though, يعني, but this is at least as I'm a surgeon, when a patient coming to me, I would like to make he lost his vision completely, or still there is, you know.
If the patient comes to this forum, I think VA
We-
is live the
Yes.
in,
Correct, and we have collected that for patients who come. We did not notice any visual improvement at the last visit. There was only minimal visual improvement at 3 months, then it returned back.
Dr. Hussam, thank you. That was very interesting topic. I just have 2 comments.
Sure.
The first comment regarding the ocular trauma. Is this published or not yet?
No, not yet
Yeah.
published.
For a future publication, you can specify which type of ocular trauma in your, whether
Sure.
open or closed
Sure.
glow. The other comment, I wish you add some video for educational purpose in this presentation.
Sure,
Yeah.
we'll
Thank
do
you.
next time.
Hussam.
Yes.
Thank you, Dr. Hussam, for nice presentation. Really, this is an important topic which we are facing in anterior segment from time to time. And we are expecting from the beginning, when we have patient already reach the stage of having silicone, that means the patient is, the eye is severely sick with almost hypotonia and all these things. And the rejection rate will be very high. So dealing with patient with such finding and with such story and all these complication, definitely the outcome will be almost poor, and same time the rejection rate will be high, especially if there is no if the patient is having aphakic, or sometimes we are doing sclerofixate during surgery, and we'll try as much as we can to remove silicone from the anterior chamber to avoid contact, and to remove it early, definitely with the consultation of retina as early as possible if the patient eye is stable. So this is important, and those patients, the outcome usually is not encouraging, but sometimes patient is one-eyed patient and you want to give them a chance. So this is the thing. My comment here is to make patient aware of the possible outcome and poor prognosis, especially sometimes in children, family, putting high hope and these things, and sometimes ended with the thiaskill eye and all the complication. Thank you very much.
Shukran, Dr. Said. Any more questions? I have a question for the retina, if they allow me. Yeah, would you prefer to use the TKP, the BMA1, or silicone for your surgery or complex care surgery? Silicone or the BMA1? Doctor? Both. Okay. Yeah. Mm-hmm.
As you said, the only real difference is the PMMA with the tangled scratched. So you should discard it after a few surgeries. The one with the silicone, by law in Spain, you should discharge it for every case. So it's much expensive to use the silicone oil because you cannot reuse it. Okay, it's not allowed to reuse this kind of prosthesis here. So the landers, it's if you have the landers back in Barcelona, they don't allow you to use it here. Okay, my point, because they say the sterilizers cannot guarantee for not to be contaminated by prionic proteins here. So that's why this is not used anymore there. But the view is more or less the same. But because when with the wide field right now, we can see very well the periphery here.
See.
Okay.
I see. And what about the silicone oil? For how long do you keep it in such complex RD?
I tell you, I'm seeing the things on the opposite way. For me, globe preservation is a good outcome in these cases. And I don't care too much if the cornea is compensated, at least they have the patient, they have the eye here. So this is not a repair surgery, this is not a phaco.
Yes.
It's a very complex surgery. Decision to make the silicone oil with a failure graft here, it means if you remove the silicone oil, retina will detach and you will lose the eye. So eye preservation is good as long as you can keep the silicone oil there. Of course, if you have a clear graft, we can discuss if there is a chance to improve the visual acuity for the patient. But unfortunately, most of the cases, to preserve the silicone oils is the only way we know to preserve the eye inside the eye. I have another comment about being a phakic cornea decompensated. There is techniques that allow you to preserve the silicone oil posteriorly here without going into the anterior chamber. And it can be done at the end of the surgery here. The sutures will preserve the silicone oil behind. There will be no contact with the silicone oil to anterior chamber, and this will prevent the graft to be decompensated. So everybody has tricks to how to do these cases here. Yeah, you can put this suture here with Prolene at the end of behind the iris here. They will keep the ball posteriorly here, so there will be no contact between the ball of silicone oil and the anterior chamber. That will be reduce the number of failure grafts on these cases.
تفضل دكتور.
I think your question was regarding the type of IOL. The IOL, BMMA or silicone IOL, huh?
No, the TKB, the Eckhart silicone or Landers.
It's okay. Now, Now the other point is how long you would you leave the silicone oil. What from my perspective that I think oil kept longer than 4 or 5 months, that you will run to complications. And not only emulsification or contact with the endothelium. Also, studies have shown that the silicone oil itself is toxic to the retina. And I think there is no indication, unless we don't expect much of fission. And the main aim of leaving the oil is for globe preservation. Otherwise, if you are expecting some fission, I think the oil should come out. If the retina cannot be held attached except with oil, this is not a failure, surgical failure. We should go and either do retinectomy or release membranes or whatever. But keeping oil indefinitely, this is only for globe preservation.
شكرا دكتور.
Again, coming back to keeping the oil forever is for globe preservation, and this is what we are doing in many cases, at least in KKH. But again, coming back to Marco's point, that if you leave it, it will emulsify, it will do endothelial decompensation. Although the globe is preserved, the patient will develop a painful bullous keratopathy, and then they will develop microbial keratitis and endophthalmitis and loss of the eye. So we need to find a balance where we can say that enough is enough, we should not do anything more, or we should remove the oil. Because obviously I'm more interested in cornea and retina guys are interested in the retina, but if you look at the whole picture, we need to see what is the benefit to the patient in the end.
I think we are both interested in the globe and the patient as a whole, and this is, we tend to forget the patients as a whole. And I think because you know the eye is not only for vision but for beauty, for cosmesis, and this we should also consider this as well. And I think rehab, from a cosmetic point of view, if you have a globe nicely formed, much easier than a physical one.
Yeah, the risk of silicone oil endotheliopathy, usually when there is a small drops that moving in the anterior chamber, that is usually irritating the endothelium. If it is silicone oil, you know, that getting in the anterior chamber with the time, let us say, more than 6 months and over, they were starting with band keratopathy first, you know, while the cornea in between clear. And this is why this patient, you know, considered it as keratopathy and then FL. But in the grafting, this is something is differ completely, you know. Sometimes with the patient, you would like to preserve the retina and to preserve the cornea. And from our side, as as a retina specialist, our objectives, if we can save the retina first, as we have the alternative for grafting many times, while the retina you don't have that chances. So there is, but I noticed that you have a lot of hypotony cases.
Yes.
And this is one of the, principal factors maybe for the.
Thank you, everyone.